Yori, have you been? Your live suddenly went off. I went to sleep for half an hour. Then I chilled for a bit. I feel better. I feel more focused. I need that. That's the strategies that I was talking about, that you underline the questions purpose first. Oh, okay. Yeah. Let me think. Hepatitis C, there will be mixing of the mother's blood with the baby. So what should I do? Maybe this. Should I give him immunoglobulins? I mean, I need something fast. She's already she already has ruptured the membrane and she's gonna give birth, and she's already in labor. So I don't know what to do. Let me go with this. Okay. Left. Okay, let me write that down. Left occiput anterior. Left occiput anterior. That's the best one. C is completely excluded. You need rapid onset. Why is it excluded? Like, you need rapid onset. I mean, I guess, like, I know that you give neonatal immune globulin to patients with hepatitis B, but maybe it's just C2. I thought that. It's weird. So the risk of vertigo is increased with operative vaginal delivery. Okay. What is the difference between operative vaginal delivery? Operative vaginal delivery versus spontaneous. Do we do anything or what? Nobody explaining this stuff? Oh, like vacuum and forceps? Okay. Yeah, so forceps and vacuum. I thought that too. Okay. It's so annoying because what if we have HIV then? What if the mother has HIV? I think we gotta give zidovudine. Avoidance operative, internal fetal monitoring, rupture membrane, hepatitis C. Okay, just because the risk is not reduced. Just because the risk of transmission is not reduced by cesarean, you just do spontaneous vaginal. Okay, fine. So hepatitis C is not complicated when it comes to pregnancy. Spontaneous vaginal delivery more than cesarean. That's all I need to know. Administration of which of the following is the most appropriate next step of management? Okay. Pelvic ultrasound shows normal uterus, normal ovaries. Beta HCG negative. What's the problem here? Pelvic examination shows a moderate amount of blood in the vagina and a closed cervix. Moderate amount of blood in vagina and closed cervix. 14-year-old. Heavy vaginal bleeding for 2 days. Menarche 12. Okay, menses typically occurs every 2 to 3 months. Mild cramp, whatever. Last. Passage of multiple clots. Okay, what is the most common cause of heavy vaginal bleeding and irregular? I think that's just normal, isn't it? Yeah. In operative, we use instruments while spontaneous. The mothers expel the baby out. Hope that helps. Yeah. Okay, we're not gonna give her estrogen. Yeah, I thought it's normal because she's still very young. This 14-year-old presents with heavy menstrual periods. A presentation consists of the diagnosis of AUB due to anovulation. Oh, anovulation. Oh, okay. Anovulatory bleeding is common in the first few years after menarche and before menopause too. In the absence of ovulation, progesterone is not secreted, and the endometrium is exposed to chronic uninterrupted estrogen stimulation. Damn. That didn't get in my mind. Okay, so anovulatory bleeding. Let me imagine that. Okay, so why is it wrong to just give her progesterone? Oh yeah, they said that multiple times. Just progesterone only contraception increases risk of irregular bleeding. Let me think, why is that? I mean, yeah, if progesterone keeps hitting the woman before estrogen does its job by proliferating the endometrium, any endometrium that is being formed is going to shed because you have constant supply of progesterone. Yeah, so that makes sense. All right. Cool. Right, let's move on. Which of the features of this patient tumor is most suggestive of a poor diagnosis? All right, so she no HER2 ER. I mean, receptor status. Yeah. Breast cancer prognosis determined by the patient's characteristics. She's 64. And the tumor's mammographic appearance. What is the mammography here? Diagnostic confirmed the presence of the mass. 1.5 speculated mass with calcifications. I mean, that's very small. 1.5 is like this. Diagnostic mammography for the mass. Yeah. All right. For which of the following complications is this patient most likely at risk? I mean, diabetes in the mother, is that diabetes mellitus? Diabetes in the mother can lead to transposition of the great arteries, but it also can lead to I think it's B. What the fuck is that, bro? Really? Oh, no way, bro. I thought that, I swear, yeah. Yeah, I know it's not that. I know it's not that. It's the opposite. What did you do the day before step 1 or the week prior? The day just before step 1, I did the free the free 120. And the week prior, I did 5 blocks a day of ambos every day. I went to the University of Buffalo library with my brother. Unilateral clavicular fracture. Wow. Oh, wow. Shoulder dystocia. Fetal fat deposition differs between diabetic and non-diabetic. As a result, neonates of diabetic mother have larger shoulder and extremity difference. Wow, I should actually make all that. I should do all this assumption right here. I should first think of shoulder dystocia and its complications. Were you stressed or anxious? No. It's actually so funny. You know, the day before, or the month before the exam, I was actually thinking about shifting the career. I was thinking about leaving medicine forever. I said to myself, okay, I'm gonna prepare for step 1. If I failed for step 1, I'm gonna leave medicine. I told myself that. So I wasn't stressed. I wasn't stressed at all. I didn't give a shit. Okay, so just a big baby complication. Which of the following is the most likely diagnosis? Alright, let's see the examination. Speculum examination is a scant amount of dark blood in the vaginal vault, no active bleeding. Normal uterus, no adnexal mass. What is she complaining about? Regular vaginal bleeding. Menarche 12. Since age 14. Menses have occurred every 30 days. Okay, however, the best 5 months. Bleeding has occurred every 2 to 8 weeks. Okay. Abnormal uterine bleeding. The patient has no chronic medical problems. Okay, is that gonna be... so the only problem she has is AUB, abnormal uterine bleeding. So she's not complaining of cramping or whatever, so it's not that. Probably it's this. Endometrial cancer is not a... She's 17, for God's sake. Leiomyomas. Her uterus is normal, it's not enlarged. Vaginal atrophy. She's 17. Alright. Okay. Okay, I think I'm improving actually. Normal uterine bleeding refers to uterine bleeding, which is abnormal volume, duration, and regularity. Okay, let's do it. We're doing some progress here. Which of the following is the best contraceptive method for this patient? All right. So on pelvic examination, the uterus has irregular contour. Okay. On physical exam, normal. Okay, no heart problem, no lung problem. Her temperature is normal. Okay. She's 170, whatever. BMI normal. Okay. She visited the hospital 8 months ago for contraception counseling. She was started on the OCP. Since then, she has missed her medication. She finds it difficult to remember to do so and has now completely stopped taking it. She recently became sexually active with his partner and wishes to have children the next 2 years. Her menses are regular with 5 days of moderate bleeding and 1 day cramping. Bloating and headaches in her menses. Her mother has PCOS and migraine. That's so severe. Copper containing IUD. Yeah, she wishes to have, so that's out of the way. Her menses are regular, moderate bleeding, and 1 day cramp. That could work. Hydroxyprogesterone acetate. Diaphragm with spermicide. Bloating and headaches. I don't know what that is. I don't think it's the best. Let's go with E. Alright. Copper containing and levonorgestrel are both effective forms of long-acting contraception, first-line contraception option. However, copper containing are associated with menorrhagia and thus not suitable in this patient. Additional IUD may not be cost-effective. Endometrial cavity deformities. Oh shit! I forgot that she had irregular contour. Maybe she had a problem. We didn't do an ultrasound. You once uploaded a travel vlog. Why did you delete it? Did I? I didn't delete it. Okay, I'll see it after I finish this. Oh damn, bro! I was about to get this right. That was perfect, actually. Okay, so IUDs are out of the way because she has a problem in her. God damn. All right. 25-year-old woman, who was inconsistent with and has now stopped her oral contraceptive. Future fertility, does not have any noted medical problems and is not in any medication. Irregular shaped uterus. Alright. Contraception can generally be classified as being permanent, long-acting, reversible, short-acting. Permanent contraception is reserved for completed childbearing and are 25 years old or more. Okay, estrogen, pills, patches, vaginal ring, progesterone only contraception, long acting. What is that? Long acting reversible contraception. Etonogestrel containing subcutaneous implants, and depot hydroxyacetate. Okay. All right. Wow. All right. So, depot medroxyprogesterone. Depot medroxyprogesterone is associated with a delay in the return of fertility and should not be used if pregnancy is planned in a year, 1 year, or less. 1 year or less. Okay, I'll just memorize it. The pot is like a big pot, so it takes time to just go away. Okay, so 1 year or less. 1 year or less. 1 year or less. So it's 3 months. The pot medroxyprogesterone acetate. So it's 3 months. Takes okay. Administration of betamethasone is most likely to increase this patient's risk for which of the following complications? Administration of betamethasone is most likely to increase the risk. Okay. No, it decreases the risk. That's preterm. I mean, maybe sepsis because corticosteroids decreases immunity. Chorioamnionitis. I mean, you're giving the baby. Patient's risk. Okay. Okay, that makes sense. Which of the following is the best pharmacotherapy for this patient? Okay, that's cervicitis. Okay, that's fibrocystic disease. Non-cyclic focal. Okay, never mind. Okay, this is cyclic bilateral mastalgia, which fetal heart rate pattern. The fetal heart rate tracing at that time shows a baseline of 140, moderate variability, and shallow decelerations. Alright, that's early decelerations. So VO, chop, so head compression. Okay. Okay. Which of the four is the most likely diagnosis? The skin overlying the breast is warm and moist to touch. Pain, itching over left breast. Leftover antibiotics, but felt no relief. How old is she? Yeah. Okay. Which of the following is the most likely cause of these findings? Klebsiella granulomatous. I mean, I don't know what that is, but I eliminate the others. Okay. Donovanosis. Oh my god, what is this? Oh, is that the one that causes the laryngeal the laryngeal lesion? Klebsiella. I think I took it in ENT. Okay, larynx. Klebsiella. Larynx. It does something in the larynx, I remember. Klebsiella granulomatous. Bacilli, encapsulated bacilli. Which of the following is the most likely diagnosis? Pelvic ultrasound shows a 2 centimeter endometrial stripe. No masses. By manual examination, slightly enlarged uterus and uterine tenderness, which is exacerbated by moving the cervix. Is that cervical wall movement? Malaise, fevers, chills. Yeah, that's PID for sure. Yeah. Please don't let me. Okay, I'll I'll be more slowly, I guess. Yo, good morning, bro. Hey, bro. Good morning. Why are you removing the angry face? Leave it, bro. It's funny. Oh my. Wait a minute. For 19. Oh. Okay. Fuck. I'm stupid bro. هيكون مقاطعة بتاع اللي انت بتشربه ده. برو. امريكا كلها مقاطعة برو. امريكا كلها مقاطعة. اقاطع ايه؟ هو انا مقاطع ستاربكس، مقاطع كل حاجة رسميا. I'll start my MBME now. wish me luck. مش هدي حالك برو. بعد ما تخلص يبقى تعالى. انا قاعد. After you finish come here. Did you purchase it online or doing it offline? Septic abortion. Lol, I know my bro. I'm just kidding. Habibi. Okay. I'm so bad actually. I'm so fucking bad. Septic abortion refers to infection of the placenta or fetus of a pre-viable pregnancy. Most commonly occurs when the retained tissue after incomplete therapeutic abortion becomes infected. I'm actually... Wait. Ultrasound shows thickened. I'll do MBM9, so offline. Okay. Did you plan on... Do you know when are gonna take the exam or not yet? So bad. I'm literally just ignoring things in the question. So stupid, bro. I need stimulants or something. I need to focus. I picked cervicitis, even though there is an endometrial stripe here. And there is the dilation and evacuation history. Thickened endometrial strip. Is that retained products of conception? Okay. That's fine. Okay. That's pure gynecology though. I'm not happy with them about that. I want some obstetrics. Microscopic evaluation of the vaginal discharge is most likely to show which of the following. Microscopic evaluation. Alright. Vaginal pH. Greenish, frothy, malodorous. Okay. Petechial lesions on the cervix. That's like the strawberry. I'm just that's actually, that pisses me off. I always mix bacterial vaginosis with trichomoniasis. Holy fuck. How do I memorize that green is associated with trichomonas? Okay, Trident is actually a gum. Trident is a green gum. Like, I remember it has like okay. I just remember Trident is green. Trident trichomonas. Okay, Trident trichomonas. Trident trichomonas. Greenish, malodorous, frothy vaginal discharge. Okay. Versus bacterial vaginosis, which is white. Okay, strawberry cervix is associated with trichomonas. Okay, yeah. So Trident, it has a strawberry flavor. So strawberry cervix is associated with trichomonas. Trident, trichomonas, strawberry. Nice. Which of the following is the best next step in management of this patient? Alright, ultrasound, 12-week intrauterine pregnancy, pap smear, high-grade squamous intraepithelial lesion. Okay, she's above 25. That's okay. Okay, are we just gonna pick colposcopy and biopsy, or is there like something that is thank God, includes screening first in women above 30? Okay. Which of the following is the most likely diagnosis? Which of the following is the most likely diagnosis? Okay, no schistocytes, no spherocytes. ALT and ST are high. Proteinuria. I would pick HELP, but there's no schistocytes and spherocytes. This is probably... There's a very severe hypertension here. Headache, abdominal pain, spots on her vision. She's gravida. 32 weeks gestation, 3rd trimester. She has a twin pregnancy, so she's more at risk of preeclampsia. So definitely not C. Pheochromocytoma? It wouldn't explain the liver ASTs. I mean, it's preeclampsia, but she has end organ damage here. It's supposed to be eclampsia. Oh no, eclampsia was seizures, right? This is preeclampsia with severe features. Okay. Yeah. Evidence of end organ damage which occurred in a previously normotensive patient. Alright, that sounds cool. Evaluation of the discharge with which of the following tests is the most appropriate next step in management? Okay. On the labia and vulva, there are several irregularly shaped scaly beef red. On the labia and vulva, there's several irregularly shaped scaly beefy red plaques. Plaques that have small pustules. Vaginal itching, dysuria, white odorless vaginal discharge. Scaly, beefy, red plaques with pustules. Speculum examination shows a thick white discharge. Okay. It's not trichomonas. It would be green, right? It would be green discharge. And it doesn't explain this. PCR? What is that? Like HSV? What does PCR tell here? HSV or what? Let me leave that. NAT. So NAT is for trichomonas as well. Gram stain. Okay, I'm gonna get this question wrong. PCR for Canada? Or culture for Canada? I don't think it's gram stain. Wet mount. So wet mount microscopy is both for vaginosis. Sorry, it is both for trichomonas and Canada. Okay. Oh wow. Wet mount is for everything. Okay, wet mount is for everything. Wet mount is for Canada, for vaginosis, bacterial vaginosis, and trichomonas. PCR. PCR is for HSV, I think. Yeah. It doesn't cause itching. It's painful. NAT is for whatever. Forget it. Yeah, wet mount. Okay. So the first step in a discharge of a vagina is just wet mount microscopy. Which of the following is the most appropriate contraceptive choice? Okay, give me these contraceptive questions. Give me. 27-year-old woman. The patient is taking calcium and vitamin D due to a dual DEXA scan that is negative 2.2, which was performed during treatment for anorexia nervosa. Since being treated for anorexia, menses have occurred every 4 to 8 weeks. These questions are getting harder. Alright, okay, step by step. Okay, so she's taking vitamin D and she's taking calcium. Okay. She has anorexia nervosa. Consistent 3 to 8 of heavy bleeding with cramps. So let's remove IUDs out of the way. The patient has smoked cigarette. Oh, smoking. So we cannot give her OCPs. Okay, give me. Male condoms and spermicide. Progesterone only contraceptives. She has heavy bleeding. This will only lead to worse bleeding. Right? Male con. Okay. Bismillah. No way, bro. Cigarette smoke is a contraindication to OCPs only in patients who are. You guys see this? Cigarette smoke is only a contraindication only in patients who are 35. Okay, why is C wrong then? Medroxyprogesterone acetate associated with decrease in bone density. Medroxyprogesterone acetate. I mean, yeah, it makes sense that we want to give her estrogen-containing contraception because estrogen improves bone health. So only in patients who are more than 35 years old. Copper-containing intrauterine device. Male condoms and spermicides are safe but not effective. I'm pretty sure there is something that worsens. Pretty sure I had a question here. Yeah, see? So just the injection or what? Which of the following is the most likely diagnosis? By manual pelvic examination shows the uterine fundus to be firm and at the level of the umbilicus. Firm at the level of umbilicus. Oh, okay. Yeah, so if the uterine fundus is firm, that is not uterine atony. Uterine inversion at the level of the umbilicus. Maybe it just like came out up like that. Uterine rupture. I mean, uterine rupture would happen like during the labor, right? Uterine rupture. Genital tract trauma. No way, no. What are the risk factors here? Forceps. Maybe placenta accreta. Or it's going to be difficult to remove the placenta. The placenta delivers spontaneously. This is not. No. I feel like it's this. Okay, why is it not urine? What is urine inversion? I don't know. Okay, I'm doing a very bad mistake here. I'm actually removing answer choices without making sure, without having a reason to remove them. I shouldn't do that. I shouldn't train myself to do that. Because if I'm decreasing my chances to get the question right. That's stupid. Uterine invasion, that's the opposite of what I'm telling my students. Uterine inversion can cause postpartum hemorrhage. However, uterine invasion typically presents with a smooth, round mass protruding from the cervix. Oh, uterine inversion. Okay, it's like rectal prolapse. Okay, yeah. Yeah, of course it's not that. Uterine rupture is unlikely in a patient who has had no prior surgery. Okay, so he gotta have a prior surgery then. Yeah, makes sense. It's in patients who have prior surgery. And it's typically preceded by fetal heart rate tracing abnormalities that are not seen in this patient. Okay, yeah, that leaves genital tract trauma, for sure. The uterine fundus to be firm at the level of the umbilicus. How does that tell us? Postpartum hemorrhage reversed to cumulative loss of 1 liter or bleeding. Hypovolemia. Yeah. So the forceps was a risk factor, like I said. Forceps was a risk factor for genital tract trauma. Damn, bro, I should study more. Intravenous estrogen? No way this is an answer. IV estrogen. No way this is an answer, bro. Probably this is anovulation too. She's young. Tranexamic acid. Isn't that the counter of TPA? Yeah, anti-fibrinolytic. That is the counter of TPA. Okay, no way that's like something. I'm not gonna lie though, I'm not sure. This is, I'm kind of sure. I'll be shocked if this is an answer. The pot hydroxyprogesterone acetate. She has anemia. Does that tell us anything? Seasonal allergies? I don't know, like every contraception question is different. I'm so tired of this. I got like all the contraceptive questions wrong. Should I watch a video about it or what? Okay, so combined contraceptive pills are first line, and then second line progestin only therapy. Okay, that's like the first line, second line. Okay, and then if the patient has some, he doesn't have any compliance or whatever, he's complaining that he's skipping doses, we just give the patient something long-acting reversible contraception. So like this, or the pot medroxyprogesterone, or the levonorgestrel injection, or the IUDs, copper containing, or levonorgestrel. Okay. Tranexamic acid, we give it to patients who have severe bleeding, that do not want to take hormonal options. Active bleeding. She doesn't have active bleeding. Okay. No active bleeding. Wow, the last 4 questions are wrong. Bismillah. Which of the following is the most likely diagnosis? An ultrasound of the pelvis shows markedly enlarged and cystic ovaries bilaterally, and free fluid in the posterior cul-de-sac. Okay. Urine beta HCG is negative. Fecal lutein cysts. That is because of beta HCG. Ruptured ectopic pregnancy. 2 days of worsening abdominal pain, nausea, shortness of breath. I mean, beta HCG is negative. Could be okay. She underwent infertility treatment and oocyte retrieval a week ago for anovulatory infertility attributed to polycystic ovarian. Okay, yeah. Chest X-ray shows evidence of hydrothorax. What? Physics shows crackles, distended, non-tender abdomen with a fluid wave. It's ascites? So ascites, hydrothorax, pulmonary edema. Probably that is that. Fatal complication of controlled ovarian hypertrophy. Human menopausal gonadotropins. Okay. I mean, that's easy. I'll just memorize it. Which of the following is the most likely diagnosis? Uterus non-tender. Vital signs are stable normal blood pressure and pulse. Amniotomy is performed at sudden onset of bright red bleeding. Okay, that's Vesa preview. Fetal exsanguation. Where's the blood coming from? From the fetus. Okay. The patient has the greatest risk for developing a malignancy in which of the following locations? Okay, let's see. Testosterone is a bit high. This is probably PCOS. Yeah, severe acne. Alright. People with PCOS at risk of developing cancer. Yeah. Unimposed estrogen. Okay. Which of the following is the most likely diagnosis? Physical examination is normal. Oh. 13-year-old girl, heavy menstrual bleeding. Wait, which of them is the most likely diagnosis? Anemia, platelets high, BMI 28, overweight, 13-year-old, fatigue, weight gain, which started with menarche 1 year ago. Heavy menstrual bleeding, fatigue, weight gain. That sounds like a... Okay. Yeah, I forgot about the anemia. That means she's... Well, yeah, that anemia makes sense because she's bleeding. Oh, regular bleeding. Okay, this is regular. Okay, that's important actually. Holy. Regular versus irregular bleeding. Damn. Regular versus irregular. This patient has regular bleeding, so all these are out of the way. Yeah. Or intermenstrual. Infection. Cervical. Endometrial polyps. Intermenstrual. reach question 30 and take a break. I can't. I'm so tired. For example, ovulatory dysfunction, polycystic ovarian syndrome, contraception complications, and pregnancy are characterized by irregular bleeding. Infection and cervical and endometrial polyps typically present with intermenstrual spotting. Okay. Sounds good. Pelvic ultrasound shows a normal empty endometrial cavity, normal ovaries bilaterally, and nexal masses. Okay, abdominal pain and vaginal spotting. She states that the pain started yesterday morning and is continuous but mild. Yesterday morning and is continuous but mild. It's located in the left lower quadrant. That she does seem to make it better or worse. She takes okay. Ectopic pregnancy? She doesn't have anything here. A positive. Blood pressure normal. She's stable. Feels like ectopic pregnancy, but like inside the abdomen. I mean, what is the purpose of repeating the HCG again? Functional. BMI is high now. Tubo-ovarian abscess. How do you give a patient with an abscess and antibiotics without drainage? How, like... Is that PID? PID. What is the treatment of PID in a pregnant woman? Metronidazole, no. Yeah, we switched from we usually give IV cefotaten plus oral doxycycline, but we switched from doxycycline to azithromycin because she's pregnant. Placental abruption. Wait. She just got C-section. How do you give her oxytocin? Bro, how do you give her oxytocin? This is so fucked up, actually. Should we give topical or oral? I don't know. Ah, okay. That is corticosteroid. I thought it's antifungal. Okay, good. Clobetasol. Which of the ones is the best next step in management? Urinalysis negative for protein and glucose. To the following is the best next step in management. Okay, 33 weeks gestation. Prenatal visit. Worsening, shorter breath. Now is it unable to walk? Okay, she has aortic stenosis. Left upper sternum border. That's pulmonic stenosis. Lungs are clear to auscultation. Your analysis is negative for protein and glucose. Wait, left. Right. So what about this complaint then? Gradually worsening, shortness of breath. Dyspnea of pregnancy. Oh, okay. Yeah. Okay, just because it's systolic murmur, you don't have to do anything. Bro, it's so annoying. Obi خرا ده. Obi guy ده خرا. اللي هو يعني I have some rules in my head that I'm applying. كل شوية اكتشف انها غلط. Where are you, bro? I was trying to call you النهاردة. فينك؟ I'll finish this. I'll finish these questions and I'll call you. Okay. I have 4 questions left. I haven't started yet, I just remembered. Lol, I haven't started yet, I just remembered. Started what, bro? Oh, you started streaming? Or started what? No studying? Started no studying? There's a delay in the stream, so say the sentence. The entire sentence. I don't understand. Oh, you haven't started studying OB-GYN. Okay, I got it. Bro, Tigi, you can actually join me and study OB-GYN with me. Damn, that's a good idea, bro. We can watch Kaplan videos. Yeah, we can watch Kaplan videos together. Bro, let's do it. What do you mean no, bro? Are you... What do you mean? What do you mean no? Let's watch it together. The last thing I want to do. Okay, I mean, get fucked in the OB-GYN exam. What can I tell you? Get fucked, bro. It's the worst subject ever, man. I'll call you استنى أنا عايز أتكلم معاك خلص الخرا ده. يعني عايز ايه يعني؟ Breast ultrasound 2 centimeter, fluid filled unilocular cyst, no internal echoes, reassurance ولا ايه؟ biopsy ايه؟ انت هتعمل fluid filled unilocular cyst يا عم breast cyst وخلاص. reassurance. That was found in the USMLE. Yes. Whatever, bro. Can present painless lump or symptomatic diagnosis ultrasound. Thin walled, well circumscribed echoes are benign. Yeah. Just paid $760 for this shit. على حاجة you pay for services you don't get. It's so funny. which is the best next step in management. Pelvic examination shows 2 centimeter cervical dilation. Transabdominal uterine ultrasound shows the fetus in the vertex position with a posterior placenta and normal amniotic fluid. Okay, physical examination shows an uncomfortable appearing patient lying on their back and their abdomen is gravid but non-tender. Pelvic examination shows 2 centimeter cervical dilation. Shows the fetus in vertex position with a posterior placenta. Okay, this is what is this called? Variable deceleration? No, this is not variable deceleration. It's my 33-year-old patient, gravida 2, para 1, 38 weeks gestation, comes to the emergency department because of abdominal pain. An hour prior to arrival, they had the sudden onset of rhythmic episodes of painful lower abdominal cramping that occur regularly every 8 to 10 minutes. They have received regular prenatal care with no known fetal complications and have no significant past medical history. Why did they sing they? Patient's pose. I don't know what is that, bro. Let me see that information. Late decelerations. Oh, the normal is acceleration, bro. أنا غبي أوي. Normal is accelerations. Peak. Okay, got that shit. Yeah. Late decelerations, so veal chop, placental insufficiency, normal amniotic fluid. Then you gotta just reposition the mom. Late decelerations, presence of fetal heart rate drop after the contraction letters. Reposition the mother. Okay, when do you give like amniotomy? Whatever. Yeah. Which of the following is the next step in management? 28-year-old woman comes to the physician because of 6 months history of amenorrhea and galactorrhea. She also reports a decrease in her sex drive during this time. 8 months ago, she was briefly hospitalized for an exacerbation of her schizophrenia. At that time, she was put on a new medication that was titrated up. She has had no hallucinations. She has no other significant medical history. Which of the following is the most... Okay, amenorrhea and galactorrhea. Okay, that's prolactinemia. You're not gonna discontinue risperidone. She's good. Yeah. Ultrasound examination is most likely to show which of the following. During speculum examination, 70 milliliters of blood clots are removed from the vagina, after which active bleeding from the cervix occurred. During speculum examination, all right. Ultrasound examination shows most likely to show which of the following: 28-year-old woman, Gravida 2, para 1 at 35 weeks gestation, is brought to the emergency department because of vaginal bleeding, intermittent abdominal pain that started after a motor vehicle accident. This pregnancy was previously uncomplicated.
The eligible countries. You can see the eligible countries are US, Brazil, France, Germany, Japan, Korea, and the UK. So how did I get in? Simple loophole. Just follow it all the way through. It's completely free. It takes like 5 minutes, and then once you do it, you will be in the program, and you can do it from anywhere in the world.
Most people get ghosted or even friend zoned by the third date. And modern, I think therefore also modern dating has become super challenging. You know, I like to say, you know, if you just scratch the surface, you will find no purpose. And today's hookup culture does more harm than you would actually.
Okay, that's a classical case of placental abruption. That is easy. Wow, I'm consistently getting 55%. Consistently getting 55%. Look at that. Damn, bro. I'm getting 55%. Holy shit. Look at my random blocks. My random blocks are good. Okay, I finished 60 questions today. I'm very happy actually, that's good. I'll finish another 40 and I'll be done with the day. So 100 questions. That's good. I think I just have 49. Let's finish that. computer. Okay, I'm gonna take a break and come back. Okay, so I'll just I'll stop the stream, I'll take a break, and then I'll start another stream.